Thank you, Professor Jain, Professor Vinita, and Dr. Neha for giving me this opportunity. And it is already late, but let us see how to make it more interesting. So, I'll be covering some of these topics and we'll show some cases how to approach the small intestinal biopsies. So, let us start with what is the normal histology of colon on the mucosal biopsies that we will see, and almost all of you know how the normal colon look like when it is oriented, when it is not properly oriented. We all know we can compare the crypt arrangement with a rack of test tubes. They are very evenly distributed and long crypts. This is the muscularis mucosae, and when it is not oriented also, then also you can see it is very evenly distributed. Now, when we say something, when a biopsy or the colon is inflamed, so for that, you have to divide the mucosa into two halves. This is the upper half, and this is the lower half. If it is a normal colon, normally we see lymphocytes and few plasma cells into the upper half. They are not really redistributed into the lower half. That is how the normal colon biopsy looks like. Yeah, unlike this one, where we are seeing, though the crypt arrangement is still preserved, but we are seeing the number of the inflammatory cells are more, and they have also redistributed into the lower half, then we'll say this is possibly inflamed. Now, what is the histology of the acute colitis? We all know acuteness or acute word we use when there is neutrophilic infiltrate into the epithelium. It may be cryptitis, it may be a crypt abscess, or there can be ulcers. So, any of this, if they are present, then we call that, possibly if the morphology or the crypt architecture is preserved, we call that it is acute colitis or acute infectious type colitis. Also, we should not, as a pathologist, we should use this term. So, but this is also many pathologists report that it is a acute self-limiting colitis, but we don't. And when we say that the colon is chronically inflamed or the inflammation is chronic, so then we'll see this is the biopsy. What is the most important finding? We are not seeing that even distribution or even arrangement of the crypts, and we are seeing there is unevenness. There are areas of crypt loss. The crypts are branching. The crypts have become shorter. Normally, they reach up to the muscularis mucosae. Here you are seeing the short crypts. So, and there is also inflammation in the background that we have already seen. So, if we see this type of appearance, we say that it is possibly a chronic colitis. So these are all features of chronic colitis. And in addition, we can also see various types of metaplasias into the chronically inflamed colon. But many times we see both the features of chronicity and activity, they are present together. And we call that it is a chronic active colitis or acute and chronic colitis. And this is the basic minimum requirement what we identify to entertain some of the differential diagnoses like inflammatory bowel disease, tuberculosis in Indian subcontinent. It is must be a differential diagnosis. Now, this type of appearance can be caused by various other persistent inflammation like Shigella, Salmonella, all these inflammations. And in other diseases like chronic ischemic colitis, microscopic colitis, radiation-induced changes, and nowadays you cannot forget the drug-induced enteropathic syndromes. But you can ask me, what are the features on mucosal biopsies what differentiate between an IBD and non-IBD type of chronic colitis? So chronic active colitis-like feature is the minimum requirement. But one of the most important feature what pathology stresses on is the presence of basal plasmacytosis, which is defined by either presence of a band of plasma cells below the shortened crypts, or at least 5 clusters of plasma cells below each crypt. At least 2 of these clusters should be there. So to call it a basal plasmacytosis. And it has been seen that if you see eosinophilic cell infiltrate along with the background chronic active colitis like features, these features are usually commonly seen in IBD like colitis. And if the segmental biopsies are usually taken, it is said that if you are seeing in 3 or more of this anatomical site biopsies, then the possibility of UC is further very high. In Crohn's also we can see basal plasmacytosis, but that is usually focal or not present. Now, basal plasmacytosis was highlighted by this British Society of Gastroenterology in 2013. And they said that in their study, it is one of the earliest feature of IBD. You can see within 2 weeks of development of IBD, when the architectural distortion is also not there, and it is one of the important, strongest predictor of IBD you can rely on. But please remember that those subsequent many societies like Italian societies and some of the American societies also stressed on the presence of basal plasmacytosis for diagnosis of IBD. We are do not see many publications based on that. So we thought, let us do a systematic study to see how this basal plasmacytosis and eosinophilia that helps us based on the published literature to differentiate between IBD and non-IBD type colitis. You can see that among the large number of the articles screened, only 5 were found which focused on these typical features of basal plasmacytosis and eosinophilia. And based on the published literature, we did not find that it is a significant finding which can differentiate between the IBD and non-IBD type of colitis. But as a pathologist, we know that it actually helps. That was followed by another study by us. We found that now you can see that this is IBD type colitis and a non-IBD type colitis. We included intestinal tuberculosis because it is the most common type we commonly see. And you can see the mucosal basal plasmacytosis really helps in many instances to differentiate an IBD and non-IBD type colitis. And if you see eosinophils along with basal plasmacytosis, that also helps to ascertain that if it is IBD type of colitis or not. Please remember that only presence of eosinophilia when basal plasmacytosis is not there is never specific for inflammatory bowel disease. So now we know that to call something as IBD, we at least have to have the architectural distortion, neutrophilic activity, and there is basal plasmacytosis, and if eosinophils are identified, that will also help. Let us see some cases. So this is a 32-year-old male biopsy from the ascending colon. For us, the biopsies are but the history is actually very crisp and short, always. And that is better for me to write here. And you can see this is the biopsy fragment what we got. So what do you think? It is IBD or inflamed or it is normal? So let us apply those questions and those criteria. If the mucosa is inflamed, we have to ask. We'll divide the mucosa into two halves, and we can see there is a lymphoid aggregate, some inflammatory cells. They are not really redistributed in the lower half. Then we'll ask another question, if the architecture is normal or not. And we know that they're evenly distributed, the architecture is normal. So we interpreted this as ascending colon biopsy within normal histological limit. Case number 2, this is a rectal mucosal biopsy. Endoscopically, there were erythema, and the endoscopist asked us query IBD. What do you think? So here also we can see there is a lymphoid aggregate. We have to be vigilant when you see lymphoid aggregates in the left half of the colon, but it is not always diagnostic. Let us apply the same questions and criteria. There is some redistribution, mild inflammation we can say, but architecture is predominantly maintained. But as we went to high power, we could see some of the polymorphic infiltrate. Polymorphs you can see both into the lamina propria as well as they are infiltrating the surface epithelium and the crypt epithelium. So what would be our interpretation? Architecture is normal. It is mild inflammation with neutrophilic infiltrate. So we reported it as possibly this is acute self-limiting colitis or active colitis or acute colitis. This is case number 3. Patient presented with colicky abdominal pain, ileocecal biopsy was taken, and we were asked, query, it is CD, query ITB. So what do you think? If the mucosa is inflamed or not? The same questions, architecture, and we have to determine if the mucosa is inflamed or not. Any thought? It is inflamed, looking like it is inflamed. Some of the focus, we can go into high power and we can see that it is really inflamed. There are lymphoid aggregates, there are a lot of inflammation. The architecture is not really normal, and we can see neutrophilic exudate also. So it is also features of activity is there. So we can say it is chronic active ileitis, at least in this focus. Now, we have to also ask really into the small intestinal biopsies when you are getting multiple biopsy fragments, are the changes are diffuse or patchy? So let us look in these biopsy fragments. we can see, we have already seen these areas were showing chronic active bilitis like changes, but look at the other fragments of the ileum. They are relatively less involved. The inflammation is less dense. The architecture and distortion is also less prominent. So what should we call? This is a diffuse disease or this is a patchy disease? So this is a patchy one. So we thought it is a patchy chronic active colitis, but please remember, not in all cases we can give a etiological diagnosis. Especially in this case, we did not find any microgranuloma, macrogranuloma or other changes. That's why we said it is a patchy chronic active bilitis. We cannot tell you the etiology. Kindly investigate further for the etiology. Let us see another biopsy, similar history, ileocecal junction, query ITB, query CD, and in the low power, we can say that it is inflamed, part of the less inflamed, the other areas are more inflamed with architectural distortion. Possibly this is an area of exudate and ulceration. So chronic active ileitis is definitely there. This is the higher power. You can see this part is more inflamed. This part is slightly less inflamed. This is the ulcerated. So possibly, again, we are seeing patchy chronic active colitis. And here the other fragment, which is ulcerated, this area is pale, we'll see later. And look at the creeps into the preserved areas. You are seeing, what you are seeing here? Kind of metaplasia. So what is this metaplasia? Panaxial metaplasia, that is also a feature of chronicity other than the architectural distortion. So this is chronic active ileitis, and that is possibly patchy. And this is the pale area on high power. What we can see, this is a large epithelioid cell granuloma. There is not only one. This is also epithelioid cell granuloma. These are the other focus. We can see there are multiple large epithelioid cell granulomas, and the granulomas are coming close together, what we call confluent granulomas. So these are actually patchy chronic active ileocolitis with confluent granulomas. Let us go through some of the differential features or common features of Crohn's and TB, because that is the most common questions we always get. So both of these diseases, the question is always query CD, query ITB, because they both most commonly involve the ileocecal junction, and also the rectum is not uncommonly involved by both of the diseases. So you can say more or less they involve the similar areas. And in most of the biopsies, we see chronic ileitis-like feature with activity. These are again patchy changes, more inflamed, less inflamed. This is again architectural distortion. These are the again other areas, less inflamed, more inflamed, features of activity. Sometimes ulcers in both the diseases can be deep burrowing ulcers or L tract like ulcers, and they can go into the muscle, and they can sometimes also perforate. Crohn's perforate more. They form more fistulas. Their features of chronic active colitis, basal plasmacytosis. Please remember, the one caveat we have to always remember that basal plasmacytosis sometimes physiologically can be seen at the ileocecal biopsies. So if you are not getting segmental biopsies, just you cannot pay too much attention to the basal plasmacytosis only in the ileocecal junctional biopsies. If you are getting segmental biopsies, you can look at the other areas and decide if basal plasmacytosis is present in other areas or not. So this is one caveat you have to remember. In both the diseases, we can see deep inflammation into the deeper layer. We can see fibrous strictures. But most importantly, what differentiates them? We have to remember these typical terms. One is large granulomas or macrogranulomas. We have one size more than 400, 500 micrometer in size, but you can at least say if the granulomas are more than a diameter of a normal intact crypt or not. Those are macrogranulomas. So the features which can differentiate if you are getting macrogranulomas, if you are getting macrogranulomas in the deeper layer of the intestine, if the granulomas have lymphocytic cuff, if you are seeing more than or at least equal to 5 granulomas, then more number of granulomas, chance of being tuberculosis is high. Okay, and giant cells though can be seen in both, but in tuberculosis we see more number of giant cells. So you will say tuberculosis based on these features. If you are seeing large granulomas into the deeper layer, confluent granulomas, if you see necrosis, possibly this is tuberculosis only, more giant cells and more number of granulomas, again chance of being tuberculosis is high. In Crohn's disease, all of you know, in 20-30% cases, up to 20-30%, we can see some granulomas, but in Crohn's granulomas, they are usually smaller, seen in the mucosa. just next to an intact crypt. We call that non-cryptolytic granulomas. And these granulomas, unlike tubercular granulomas, they're ill-defined. They're formed by epithelioid or normal histiocytes and inflammatory cells, but less circumscribed. Okay. So these are pericryptal microgranulomas. Microgranulomas can also be seen in the tuberculosis, but they are usually relatively well defined. And if AB is positive, then it is tuberculosis, obviously, but positivity is very low because intestinal tuberculosis is a paucibacillary disease. So what is the diagnosis in this case? Look at these different colored words because these are the terminologies we should use. So this is a patchy chronic active ileocolitis with multiple large confluent epithelioids and granulomas in the submucosa. Features are favoring of ITB. So that was the diagnosis in this case given. But please remember, in Crohn's disease also, this is the Crohn's and this is tuberculosis, we can see macrogranulomas in few cases. So there will be some scenarios when the patient is phenotypically Crohn's, but you can see large granulomas. But in practice, most of the cases, in 90 to 95% cases, large granulomas, if you see, first possibility you have to suggest favoring tuberculosis. Later, if the patient don't respond to ATT, the diagnosis can be reversed on for subsequent MDT. So that is very important. And it is also important to know the site of biopsies and the number of the biopsies. We are highly dependent of the biopsies where from it is being sent. Look at this area of the ileocecal junctional mucosa, and this is the XI specimen. You can see if the biopsies are taken from this area, will not see anything. If the biopsies are taken from this ulcerated area where you are seeing deep ulcers and the granulomas are also more condensed in that areas, okay? So you are seeing so many granulomas in this area. So if a biopsy is possibly taken from this area, so you are possibly going to get those granulomas on mucosal biopsies because these are very superficial. And if they are taking from the other areas, then possibly will not see the granulomas. And it is always said that now, number of the biopsies are very important to differentiate tuberculosis, identify tuberculosis. Normally, it is recommended to take 6 to 8 mucosal fragments from these areas. That will help you to identify more number of granulomas, and also some of the fragments can be sent for the other ancillary tests like culture. Case number 5. This is a patient present with rectal bleeding and tenesmus. Multiple colonic biopsies were taken. And you can see this was a segmental biopsy. And most important, we know this is a chronically inflamed colonic biopsies, and all fragments are almost equally involved. So based on these findings, we can say that this is not patchy. This is possibly a diffuse chronic colitis. Okay. And let us see in high power what we are seeing. So there is architectural distortion, crypt loss, and look at the basal zone. We are seeing lymphoid aggregates. Lymphoid aggregates into the basal zone near the muscularis mucosae is another feature of ulcerative colitis, but that is not very dependable. But if you see in the other areas, you can see the basal plasmacytosis, and here you can see better both the eosinophilia and basal plasmacytosis into the zone, and it is a diffuse disease, chronic active colitis. There are ulcers, there is no granuloma. So we can say that this is a diffuse chronic active, sorry, it is my mistake. This is a colitis with basal plasmacytosis and mucosal eosinophilia. The features we are favoring of ulcerative colitis. So that should be the wording we should use. We all know how to differentiate UC and Crohn's. In UC, we always see a right to left gradient. The left colon is more commonly involved if you go from the ileal areas. And in the Crohn's disease, we know that disease can be patchy. We have already seen that. And this is the differentiating features already we have talked about. But it is also important to know that presence of neutrophils and identifying an IBD is not sufficient. Neutrophils also we have to grade. That is an activity for us. And presence of neutrophil also, correlates with the fetal calprotectin positivity, endoscopic presence of erythema ulcers, and histologically also basal plasmacytosis. Because basal plasmacytosis in more commonly has been identified in active IBD. There are many scoring systems which is available. GBOY score is very well validated and can be used for the clinical trials. But for routine use, Nancy index we commonly use because this is very easy to use. On the other hand, DCS score, which has been reported of late in 2020 or so, there are three features which rely on. One is diffuse pattern if the disease is diffuse or it is very patchy, less than 50% or more than 50% of the all segment involvement. Then chronicity. Chronicity means either mild crypt distortion or there is marked lymphoplasmacytosis C2 like this, and activity. Are there neutrophils in the lamina propria or presence of crypt abscess or ulcers A2? So like this. So in our case, what should be the grading? After writing all this, we have to grade, we know. So the activity score, histological activity, it is Nancy's grade 4 because there is ulcer, and it is DCA, diffuse involvement D2. It is C2 because significant lymphoplasmacytic infiltrate, and there are presence of ulcers. So it is activity 2. So thus it should be graded. Let us see case number 6. This is 42 female presented with abdominal pain and multiple ileocecal junction superficial ulcers. What you can see? Do you think this is tuberculosis or Crohn's or anything? So what are the findings? So these are the ileal fragments. These are possibly from the cecal area. Inflamed or not inflamed? So at least we can say that the cecal fragments or colonic fragments are possibly inflamed. There is some chronicity, some branching we can see. The ileal fragments are possibly not very much inflamed. This is the hypod of the cecum, and this is the other fragment we can see. So it is a patchy colitis or patchy chronic active colitis. So would you jump to make a differential diagnosis of either TB or Crohn's? So what is your idea? So we also thought it is a patchy chronic active, but always we go into high power and look for if there is any other etiology we can produce patchy chronic active ileocolitis like change. What we can see, these are the amoebic trophozoites. So this is just to give you an example how the features can be mimicking, okay? So this is the amoebiasis, which is presenting with acute chronic active colitis like change. This is another case, 53 male. So since 3 to 4 weeks, there is abdominal pain presented with multiple ulcers, and we were asked query IBD. This is the transverse colon biopsy. What do you think? It is chronically inflamed or it is normal? Mostly it is looking like normal. This is the descending colon biopsy. What do you think? It inflamed or not inflamed? It is inflamed. It is chronic inflammation or acute inflammation. Somewhat chronicity is there. There are some crypts which are dilated, and we also identified some crypt abscesses and apoptotic abscesses. So this is focal changes, but look at the rectum. It was mostly ulcerated. Okay, there was no preserved mucosa, but we tried to see if there is eosinophils. That is not there. We tried to see if there are basal plasmacytosis. We could not determine if basal plasmacytosis is there or not. While we are examining and thinking if it is IBD or not, we found this type of inclusions. What is this? This is a cytomegalovirus inclusion, and it has to be confirmed by CMB stain. And always please remember, whenever you are identifying CMB and doing an IHC, try to say per segment biopsy means one biopsy is taken from one segment, or two fragments are taken from one anatomical area. You have to say if you are seeing more than 5 inclusions or not. That is very much important. That usually correlates with the CMB titer, and that helps in deciding the treatment. So this is the CMB inclusions. So this is not an IBD. This is a CMB colitis, and which is mimicking like an IBD. This is the 43-year-old male post-renal transplant presented with diarrhea. What do you think? Colitis, chronic colitis? Looking like there is crypt distortion, but look at this area. Eosinophils are not there. Basal plasmacytosis is not there. Crypt distortion is there. Here, what we could identify, there is a patch of mucosa which is totally devoid of any crypts. But what are lying there? There is the crypt basal cells and the neuroendocrine cells. These clusters are only lying there. So what is the diagnosis? So this is in that typical clinical information. This is a feature of grade 4 GVSD. Okay. So not only the chronic active changes, you have to look at the other features, which is very important. If we talk about the mimickers, anything which can cause a mucosal regeneration in a background of mucosal damage in the form of neutrophilic infiltrate, that may mimic an IBD. Okay, that can be an infection, that can be a drug, that can be a chronic ischemia or anything. These are some examples I will just rush through. These are chronic ischemia, acute and chronic ischemia rather. You can see that there are features of crypt distortion here. This is radiation-induced colitis. You can see a lot of crypt distortion and activity is there. These are diversion colitis. You can see mucosal ulcers. Diversion colitis, one helpful feature is identification of this type of prominent lymphoid aggregates into the mucosa and submucosa. But here, basal plasmacytosis is usually not seen. This is a CVID colitis, and you can see just neutrophilic activity and all you can identify along with prominent lymphoid aggregates into the small bowel. So this is another mimicker, but most importantly, you should not forget drug-induced colitis, which can mimic an IBD, especially mycophenolate and immune checkpoint inhibitors. Nowadays, we should not forget. So whenever we are seeing chronic active colitis like changes, always look at the form. We usually don't get the history, but we usually, in all discrepant cases, MDT is done. That's why we came to know. This is one case, but for 23 male presented with a recurrent large bowel type of diarrhea. What he will say, this is a chronic colitis or chronic colitis, looking like there is architectural distortion. But what is very important to identify, the other features are there or not. We cannot jump to a diagnosis of IBD. Let us look into this part. Though the crypts are short, the basal plasmacytosis is missing. There is not many eosinophils. But what we identified, all the crypts are showing prominent lymphocytic infiltrate as well as there are apoptotic bodies. Can you identify this? So, and we asked the clinician if there is any history of immune suppression or transplant. It was not. It was discussed in the MDT, but these features were very prominent, unlike conventional IBD. Then what it was decided to send for the exome sequencing, and what we found that it is CTLA4 gene mutation this patient is having, and this is actually a CTLA4 mutated colitis. CTLA4, so if you are giving a drug and blocking the CTLA4, you will see the same thing, okay? That's why drug-induced colitis is also, you have to remember, and CTLA4 gene mutation also predispose the patient to develop autoimmune inflammation and also IBD, and it can mimic a Crohn's disease. We have to remember that. This is possibly the last example. This is a 43-year-old female, and it was a referred case. She presented with recurrent hematochezia. The diagnosis was revolving around the Crohn's and ITB. She was symptomatic since 2 to 3 years of her life. She is 43 now, and it came from 2 hospitals where it was identified as Crohn's disease. And in our hospital also, one of our assistant professor thought it was Crohn's disease. See this section, we got 4 blocks. This part of the ileum is looking normal. This part is totally ulcerated, and there is a stricture. So it is an ulcerostricturing disease. So there is nothing wrong to think initially that it may be Crohn's disease. You can see some distortion. So you can also say, sir, this is patchy chronic active with strictures. I will agree to that. But what was very unlikely, why this patient was not fitting clinically into the Crohn's disease, because there was no increase in the inflammatory markers, there was no hypoalbuminemia, no signs of intestinal failure, no creeping fat, while the patient was having intestinal resection. The blocks I was showing, the intestinal resection was done in last year for recurrent hematochezia only. What was not medically manageable, then a resection was performed. So what is the diagnosis? In this case also, MDT was performed, and we said that though it looks like Crohn's, it is not fitting clinically into a Crohn's disease. Let us look back to the other blocks. If anybody can suggest what you are seeing, anything abnormal, these are the other blocks, not that block what I just showed. Anything. So you can see the mucosa is totally normal, but what is very abnormal? Look at the muscle layer. It is gradually becoming thinned out, okay? It is almost lost here. And you have to also remember that the intestinal wall has to be oriented, okay, to identify these changes. So looking like the muscle layer is rarefied, In SMA and Desmin stain also, we can see the muscle layer is lost. This is the internal control, muscularis mucosae. You can see that is present, normal. So this is the high power. You can see the muscle layer is possibly replaced by fibrosis. This is the high power. You can see it is rarefied and there is fibrous infiltration, which was identified or confirmed on serious red stain. These are the collagen, which you can see infiltrating the muscle layer. We have to always remember that there are other things which can also cause intestinal ulceration, intestinal strictures. One of the paper will be presented by one of our assistant professors today. You can see that also has a genetic abnormality that mimicked Crohn's disease. And always remember those ulcerations or strictures can also be caused by uh, a myopathic disease which is causing peristalsis since over the years, and that is causing bacterial overgrowth syndrome. So this is actually what we are seeing. This is an atrophic type of myopathy. There are three variants. The third variant, this is autosomal recessive and only intestinal involvement is usually seen. This patient did not have any other symptoms. The urinary bladder was absolutely normal. Okay. So then we decided to send for the exome sequencing, and what we found that it is actually a visceral myopathic pattern. The pathogenic variant was found that this is the actin, gamma actin gene 2 mutation. Okay. In myopathy, this type of familial visceral myopathy, you can see alpha actin, gamma actin, or myosin gene mutations. So this is a rare case where you could see the histological features mimicked Crohn's disease initially. So what is the diagnosis in this case? This is a familial visceral myopathy, atrophic type with possible bacterial overgrowth syndrome at the IC junction. Please remember, though it looked very simple today, but we did a nationwide survey-based study where we could identify there is a lot of variability among the pathologists, and these are the pathologists who usually handle the GI biopsies, which comes with the diagnosis of query IBD. See, in all segments, you can see variability. So we have to follow an approach. What should be the approach? Like what we have seen today, we have to first ask if the mucosa is inflamed. Architecture we have to see. We have to decide if it is only chronic or chronic active. If we have to see basal plasmacytosis and eosinophilia are there or not. We have to then decide if it favors IBD or not favor IBD. Then always we have to correlate with the clinical, endoscopic, and radiological correlations, because it may be Crohn's to me. I have seen you example, it is not phenotypically Crohn's and not responding to treatment. That you have to always see. You have to see the disease is patchy or diffuse. We have to see if there are microgranulomas. If it is fitting into one of the types, you have to classify, or you can say this is unclassified. Look for associated infections and look for dysplasia, which I am not covering today. So as a pathologist, you have to always know and guide your clinician that it is always best if the segmental biopsies are separately labeled and separately sent to us. That is very important. It is also important for us to identify if but to get the biopsies mounted on the filter paper. That is usually not done. Sometimes even in our institute, it increases the time, it increases the cost of the procedure, because that is related to the time. This also increases the cost in private setup. But if you get a oriented biopsy, we can see that you can identify the basal plasmacytosis very well, and it is always desirable. And also remember that where from the biopsies has been taken, we have to know, because it has been seen that if the biopsies are taken from endoscopic areas of erosion or ulcer or granular mucosa or erythematous mucosa or loss of vascular pattern, see how the identification of basal plasmacytosis and neutrophilic activities are varying. On the other hand, if you are taking only from an area where other changes are not there, only loss of vascular pattern is there, you will possibly identify less basal plasmacytosis. So for mapping, we have to get segmental biopsies from different sites, if possible, not always possible, but if possible, that is very desirable. And as a pathologist, you have to know that If you are getting separately labeled vials, then separate description for each site we have to give. Number of the biopsy fragment examined you have to mention. Are the changes diffuse focal? Basic histological changes of chronic active colitis are there or not? Additional histological changes, all we have discussed today should be described. Then you have to say, you have to mention everything in detail. Then you'll say it is favoring IBD or not favoring IBD, what is the type, and histological scoring you should not forget. Scoring is important also for the follow-up biopsies. We have to remember that if you are not doing scoring on the baseline biopsies, how to compare if it is improving or not. Look at how do we classify the follow-up biopsies. If the architecture is normal, has become normal, there is no neutrophilic activity, not much inflammation, we say that it is complete normalization. If we see the architectural abnormality is still persisting, there is not much inflammation or activity, we say that it is quiescent colitis. Or if we see along with architectural distortion, neutrophils are there, we say that it is active colitis. Please also remember that we have to follow this 5-tier system. It was described by Dr. Pai's group, and this actually helps because in quiescent colitis, you have to also comment if basal plasmacytosis are there or not. If a patient has quiescent colitis with basal plasmacytosis, it is very likely that there will be an active clinical relapse in very near future. On the other hand, in a patient of quiescent colitis who don't have basal plasmacytosis, further complication or hospitalization is expected to be low. And in all cases of clinical flare and steroid-dependent UC, we have to always do CMV IHC. Histology alone is not enough, or PCR if the facilities are there. So what we learned today, we have to have some criteria also that you have to discuss with the gastroenterology colleagues. When the endoscopic mucosal biopsies are adequate, as a segmental taken from the areas of mucosal pathologies as well as uninvolved region, at least 3 to 4 weeks after the symptom onset. That helps because I told histological architectural abnormality, that appearance usually comes after a month or so, and the biopsy fragments are oriented. Histological interpretation in those cases yield good result. What is needed? Mentioning the site of biopsies, separate labeling, endoscopic and radiological detail must be there. Important for pathologists, we have already discussed, we have to score, we have to do the CMV staining, we have to see if there is any other infections or not, and then we have to follow that particular approach and interpret. Histological evaluation of follow-up biopsies, everything will be same, but always please remember basal plasmacytosis present or not, that we have to always mention. But what I want to stress through the cases I have shown, not all chronic active colitis are IBD. There are many mimickers, and in many times an MDT meeting only can give you that that information that it is not clinically fitting and we need to do more. So with that, thank you so much for the opportunity again.